genitourinary symptoms, one of the most encountered symptoms in medical wards. However, you can also foresee such symptoms in the pre-op and sometimes in the post-op patients. And the most common of them is the change in the amount of the urine output in the last 24 hours. Oliguria and anuria, both of these symptoms definitely pose a risk and threat to the individual's health, as well as it's a source of nuisance for the treating physician or the surgeon. As you all know that hemodynamic stability is the most important component of body's ability to heal, whether the underlying illness is a medical issue or it's a surgical problem. If the output of the urine changes due to the hemostatic disturbances or due to homeostatic mechanisms fault, the overlying or underlying pathology might worsen owing to the fact that the electrolytes and the fluid balance is altered in the body. For labeling a patient to be suffering from oliguria or anuria, you should first be able to know what is the normal urine output of an individual. 0.5 milliliters per kg per hour is the minimum urine output of any healthy individual. If the urine output decreases from the said stat, the individual would be suffering from either oliguria or anuria. As far as the exact definition of oliguria or anuria is concerned, there is a bit variation among different authors and in different books. However, less than 500 ml of the urine output in the last 24 hours is definitely characterized to be categorized as oliguria. And an individual whose 24-hour urine output is less than 100 ml per 24 hours is rightly said to be anuric. The diagrammatic representation is actually just a clue for an individual who is suffering from anuria will excrete the urine not more than a cup a day. However, in cases of oliguria, it is half a liter. On the other extremes is the polyuria, which is not the topic of concern of today's lecture. So oliguria is definitely a decrease in the urine output in the last 24 hours, and the normal urine output is 0.5 ml per kg per hour. And when the individual suffers from a urine output less than 0.5 ml per kg per hour is referred to as suffering from oliguria. And anuria is just 50 to 100 ml per 24 hours. There is some clinical clue or clinical hindrance in labeling a patient to be suffering from oliguria or anuria. Any individual who is suffering from oliguria or anuria must be evaluated for obstruction in the urinary tract as well, because these changes in the urine output might be pre-renal, intrinsic renal, or post-renal. The post-renal causes of decreased urine output are, for example, a stricture in the urinary tract, a big stone that is hindering the outflow of the urine, or some post-surgical stitch, scar, or any other stricture. Therefore, the presence or absence of an obstruction distal to the kidneys anywhere in the tract, whether it is in the ureters or in the urinary bladder or in the urethra, must be ruled out. We'll discuss it in detail as the lecture flows. So, is it always pathological? The urine output, the change in the urine output, is it always pathological? Well, it is not actually. The amount of the urine which is excreted from the body depends upon the effective circulatory volume within the vessels. If a person is suffering from loss of the fluid, like he is or she is suffering from excessive vomiting or diarrhea, or any hemodynamic compromise like excessive blood loss. All of these conditions would lead to a contraction in the extracellular volume compartment, and this contraction of the extracellular volume compartment would be sensed by the juxtaglomerular apparatus in the kidneys, and in turn causing a fall in the GFR due to the release of renin, angiotensin, and all at the same time aldosterone will try to conserve the fluid and the electrolytes to expand the compromised or decreased extracellular volume compartment. Therefore, an individual who is suffering from hypovolemia from any reason would have also a decrease in the urine output, which is compensatory, not pathological. It is compensatory to increase the amount of the fluid or to return the amount of the fluid towards a normal level in the extracellular fluid compartment, thus maintaining the perfusion of the kidneys and the vital organs to a normal level. On the other hand, if an individual's kidney got hit either by a toxin, a drug, a metabolite, or bacteria or virus or vasculitis, whatever is the etiology, if the kidney itself is hit, definitely then the acute kidney shutdown is pathological. Therefore, a careful history and relevant examination would give you a clue that the oliguria or anuria in this particular patient is either a sequel of another disease or itself is the pathology which is damaging the individual. So, three major categories of any change in the urine output are either the injury is somewhere prior to the kidneys, pre-renal, like vascular or effective circulatory volume changes, or the etiology lies within the renal parenchyma itself, or it is somewhere outside the kidneys, from kidneys up to the outflow tract, anywhere. And these are categorized as pre-renal, renal, and post-renal etiologies. Now, this is an important part. From history, you get a clue that, for example, a patient is suffering from heat stroke, had a lot of sweat loss, the effective circulatory volume falls down, and now he is presented in the emergency department with confusion, hot skin, and decrease in urine output or no urine output. Such an individual is already suffering from pre-renal injury, pre-renal type of injury, because of the decrease in the effective circulatory volume. You need to replace the fluid, replace the lost fluid and electrolytes to augment or to improve the blood flow towards the kidneys, improving the GFR, and ultimately the urine output will improve. On the other hand, an individual presented to you with sore throat and at the same time with decrease in the urine output. There is no prior history of fluid loss, no diarrhea, no vomiting, no diuretics, no laxatives, no blood loss, just sore throat followed by decrease in the urine output. Such individuals are suffering from an intrinsic renal injury due to the antibodies which are formed with a group A beta hemolytic streptococci, and they have a structural homology with the glomerular antigens. So the antibodies which are formed in the individual due to the infection due streptococci, these antibodies start damaging the glomerulus itself, causing glomerulonephritis and acute kidney injury. And there is another example of an individual who is a 60 years old male, and he presented to you in emergency with a decrease in the urine output which was gradually progressive. Initially he had a change in the stream, that is thinning of the stream, then he had urgency, hesitancy, and post-void dribbling of the urine, and now he is suffering from no urine output, anuria. But at the same time he also complains of lower abdominal discomfort. Such an individual is suffering from obstructive symptoms. He has lower urinary tract symptoms, and now there is complete urine shutdown along with the pain in the suprapubic region. This pain is due to the underlying distended bladder, and this individual is suffering from probably due to the prostate enlargement or a stricture in the urethra. So the history will guide you what to look for in examination and how to categorize the patients into pre-renal, renal or post-renal causes. Now let us take up the pre-renal case. In the pre-renal causes, the individual's circulatory volume or extracellular fluid compartment got shrunk. Such an individual on examination will illustrate the signs of dehydration. Like the signs of dehydration are thready, weak pulse, rapid pulse, hypotension, orthostatic hypotension, dry axilla, dry mucosal surfaces, sunken eyes, dry oral cavity, loss of skin turgor, and obviously a decreased urine output. On the other hand, the individual who is suffering from renal disease, whose kidneys are not effectively working due to some bacteria or virus or drugs, and in such an individual there is no loss of fluid. So the extracellular fluid compartment would be normal and there will be no signs of dehydration in this individual. The individual would be either euvolemic or hypervolemic. That is, the individual whose kidney is not functioning adequately and he had no loss of fluid from any part of the body. He or she would be then retaining the fluid as the fluid is not going out of the kidneys. And such an individual might have a raised jugular venous pressure, presence of fluid in the third spaces, that is pleural effusion or ascites or pericardial effusion. Due to the pleural effusion, patient might be dyspneic as well, and also he might start developing retention of the fluid in the periorbital area or the dependent area, that is edema. And the third scenario, in which the individual was an elderly male with obstructed urinary symptoms, there would be no history of fluid loss and there would be no findings of fluid accumulation as well. However, the area which is painful would be tender on examination as well, and as you already know, the urinary bladder is a pelvic organ until and unless it is filled with the urine, then it becomes an abdominal organ. So on palpation of the abdomen, you will find a circumscribed swelling in the hypogastric region, which may or may not be tender, and the percussion node would be dull over this filled urinary bladder as well. In such an individual, as soon as you pass a urinary catheter, the obstruction is relieved and immediately the urine bag will be filled with the urine, 2 to 3 or might be 4 liters, and the patient's discomfort would be relieved, indirectly indicating the presence of an obstructive etiology. Therefore, history and examination both will help you and guide you to identify the underlying cause, whether the individual is suffering from this oliguria or anuria due to some pre-renal cause or renal cause or a post-renal cause. Isolated urine volume, that is just considering the amount of the urine which is passed per day, is not a good indicator of kidney health. Reason being, the kidney is a vital organ which is not only filtering the blood, it is also maintaining the fluid balance, electrolyte balance, and some of the glycogen and erythropoietin activities as well. In the kidney, there is a portion of filtration in the glomerulus. There is a portion of tubular function which either absorbs or excretes the fluid and the electrolytes. Therefore, if a person or individual is suffering from kidney injury, it doesn't mean that he or she will have a decreased urine output. He or she might have a normal urine output because the tubular reabsorption function is reduced. I may rephrase it that the person is suffering from a low GFR. He is not filtering the amount of the fluid which is required to be filtered per day through the glomerulus, but at the same time he or she is not reabsorbing the fluid from the tubules. Therefore, the amount of urine will remain the same as is of a healthy individual, but actually that individual is having a problem at the filtration level. Therefore, isolated urine volume is not a good indicator to decide whether the kidneys are actually functioning or not. It is the collection of the symptoms, the uremic symptoms, the fluid overload presentation, the toxins, the drugs in use, the disease underlying, all of them collectively will identify the health of the kidney. Anything which is sudden in onset is definitely alarming, as is true for the pandemic of COVID-19. Similarly, sudden onset in the urine volume status changes is definitely alarming. Sudden onset of urine volume exceeding the normal amount or sudden onset of urine volume decreasing from the normal amount is definitely alarming. Need to look for the underlying cause. For an obstructive etiology, I am not talking about the pre-renal or the renal, but the obstructive etiology, the post-renal etiologies. For the obstructive etiologies, the urine output leading to oliguria or anuria only happens when both the kidneys are obstructed. I am going to rephrase it. An individual who is suffering from obstructive pathology and that obstructive pathology is leading to a decrease in the urine output, that the obstruction then needs to lie somewhere where both the kidneys are affected. That is, either the obstruction is in the urethra or in the urinary bladder or both ureters. Or an individual who has a single functioning kidney would suffer from obstructive nephropathy from anywhere in the tract of that solitary functioning kidney. But for the individuals who have two kidneys and they are both in functional status, the hindrance should be somewhere where there is a common outflow tract, that is either the urinary bladder or the urethra or both the ureters. Now, how to localize the obstruction or the post-renal cause? I've already mentioned that if a person is having a solitary kidney, anywhere throughout the tract, obstruction can lead to oliguria or anuria. However, in cases of bilaterally functioning kidneys, the obstruction might lie in both the ureters or in the urinary bladder or in the urethra. Further, the localization of obstruction can be done by the presence of pain. For example, if an individual is suffering from pain in the ureterics due to some stricture or renal stone, such an individual, when is given a fluid challenge, would result in worsening of the obstruction and worsening of the pain as well. Similarly, an individual who has obstruction at the neck of the urinary bladder, he or she would have a discomfort in the midline of the abdomen because of the distension of the urinary bladder. An individual who is having the obstruction at the level of renal pelvis would present to you by holding his flank and gripping the flank with the hand, indicative of the etiology or the responsible insult in the renal pelvis. And such individuals who are suffering from obstructive etiology, when are catheterized to overcome the obstruction, whether the obstruction lies in the urethra or in the urinary bladder or it lies in the bladder outflow tract, the catheter when passed would relieve the obstruction and the urine output increased. So what to look for, or after history and examination, what investigations, relevant investigations you would order for an individual who is suffering from oliguria or anuria are the investigations which would tell you or guide you about the renal function status, and that will be the renal function tests, urea creatinine levels. The increase in the urea and creatinine level helps you to identify the insult in the renal system. The ratio of 40:1. If urea is increased 40 times as compared to the increase in creatinine, that is indicative of obstructive or prerenal cause. And ultrasonography or abdominal imaging would guide you about the renal parenchyma, the difference, whether the ultrasound is able to differentiate between the cortex and medulla, whether there is some dilatation of the renal pelvis or any obstruction or stricture throughout the urinary tract, presence of any tumor or stone in the urinary bladder as well. And a simple urine analysis can guide you the presence of some bacteria or crystals or casts. And in the end, how to manage the cases? Definitely the oliguria and anuria, they are the symptoms or the signs which are elicited by the physicians or the concerned doctor. The oliguria and anuria, they are to be dealt with according to the underlying etiology. Each decrease in the urine output is not treated with loading the patient with the fluid, depends upon the underlying etiology. Thank you very much.